Yeah, thanks. Hey, everybody. Very happy to be here. I'm going to talk a little bit about our viral persistence work, the lessons we've learned from our observational studies, and the first round of clinical trials. I want to begin by acknowledging my research team in San Francisco. It takes a lot of people to be able to make this happen, and it's great to work with them every day. So our program in San Francisco is called LIINC, which stands for Long-Term Impact of Infection with Novel Coronavirus. And we launched really in the earliest days of the pandemic, knowing that we weren't very well positioned to understand acute COVID, but we were really interested in what would happen to people after they had COVID. And that was not, at the time, a major focus. We've been in continuous operation since that time. Have enrolled over 1,200 people, conducted over 6,000 visits, banked, and I think more importantly, shared tens of thousands of biospecimens with dozens of collaborators, including many people in this room. And since that time, we've developed a tissue biopsy program for living donors to provide tissues to inform the biology, an imaging program, and a clinical trials program that I'm really proud of and is really sort of exciting and fun to be a part of. So there was a really beautiful talk this morning on the growing evidence of SARS-CoV-2 persistence, and I won't talk too much about this, but just to say, at the beginning of the pandemic, I was not a believer in SARS-CoV-2 persistence, and I have been, become more and more convinced over the course of the pandemic by the data that have emerged. This is a nice review by Amy Proal from a few years ago cataloging the evidence for persistence. And I think the summary here is that, all of these studies are small. None of these studies is perfect. But these are independent groups, independent cohorts, different assays, all kind of converging on the same or similar observation that this virus is persisting in at least some people. And there's actually, somebody alluded to this earlier, I can't remember who, but there's actually an animal model of coronavirus persistence, which is in cats who can get feline infectious peritonitis, which is caused by a coronavirus that persists in granulomas in the GI tract, can mutate and cause chronic disease that actually can eventually progress, and is treated with anti-COVID drugs. So it's a pretty compelling and interesting model, and I think a good place for us to interface with the veterinary scientists. So when the reports of persistence emerged, I basically said, I'm a skeptic and I'll only believe this if we can see it in LIINC. And so what we did was, after David Walt's group published that paper that was shown earlier, where they identified a high proportion of a small number of people with spike persistence over a year, we basically partnered with them, and what we did was we sent them 250 pre-pandemic plasma samples that were collected and processed in the same way by the same people in the same labs as our post-COVID samples. And then we sent post-COVID samples from about 200 individuals across multiple time points up to 14 months post-COVID. And what was really important about this pretty simple study was that almost all of these samples were collected before anybody on the planet had received a vaccine. So one of the critiques of this field is like, oh, you can't tell if it's due to vaccination. So the data I'm showing you cannot be due to vaccination. And then this was also well before the Omicron era, where reinfections became ubiquitous. So this is not attributable to reinfections. And we did Samoa looking at various antigens with David's group. What we found in the true negative samples was that 2% of them were positive. So those are false positives. Those people, it's impossible for them to have had COVID. It's a false positive detection in 2% of the samples, which means that the assay is 98% specific, which is good but not perfect. But then when we looked at the post-COVID samples, what we found was a significantly higher proportion of detection 3 to 6 months post-COVID, 6 to 10 months post-COVID, 10 to 14 months post-COVID. You will notice on the y-axis that this is not a huge proportion of samples that have this. It's not 50% or 80%. It's, around 10%. But it's there across all of these time bins, and it kind of nicely goes down over time. There's not a p-value for that, but I find that quite interesting. And then as a clinician, what was also interesting to me was that people who had been sick enough to be hospitalized with COVID were twice as likely to have this as people who were not hospitalized. And even among the non-hospitalized people, those people who just said, I was really sick at home with COVID, were 3 times as likely to have this compared to people who said, oh, it was mild. We've now extended this out beyond 24 months. The observation is similar, and these relationships also hold up. So this is actually not long COVID, right? This is all comers. I think that the evidence for viral persistence as a cause of long COVID is weaker, but we are making progress in defining these relationships. So this was a study that was also shown earlier where David's group compiled results from all of the cohorts on which they had run Simoa, including ours and including a large proportion of recover participants. And they found a statistical relationship between antigen detection and the presence of long COVID symptoms. I do not think that this is a definitive study. I think that this study is sort of a first step signal finding study that really needs to be built upon. I get emails every day about why can't I get this test for clinical care? This test is not ready for clinical care. If I were a patient, I do not think that this test would be helpful in like an individual case. But what I think that this study actually shows is that there would be tremendous value in doing a much larger, deliberately selected study where we have hundreds of people with each different phenotype of long COVID, and we can look at the relationship between each of these antigens across those groups. Gaps in this study was that there was not necessarily standardization in terms of the timing since infection. It did not robustly account for reinfections and vaccinations, and it still did not include enough fully recovered people, in my opinion. I also think that we need to be looking at multiple assays, not just Simoa. And so it'd be nice to use sort of orthogonal measurements to see if we can consistently identify a cohort with persistence. So we're doing this now in LIINC. David's been very generous in running more samples for us. But really, ideally, this would take place in a much larger cohort like Recover. So I wanted to also mention, we talked a lot about direct evidence of persistence, but there's also a lot of indirect evidence of persistence. So Mark Painter, who's a postdoc in John Weary's group at Penn, has been studying samples from LIINC and makes this really interesting observation that among those with long COVID, about 25% of them have evidence of persistently activated spike-specific CD8s in comparison to a smaller proportion of people who have fully recovered. You'll notice that that 25% is like sort of reminiscent of the proportions that we're talking about when we're talking about antigen persistence, which is quite interesting. And then also when we look over time, it seems that when we look in the long COVID group, a higher proportion of people in that group have consistent spike CD8 T cell activation over a full year period compared to a much lower proportion in the fully recovered group. So some indirect evidence that this might be going on. These are data actually that we've never shown before on innate immunity potentially related to viral persistence, which is done by a grad student in Tim Henrich's lab. And so what we're doing is we're looking at different NK cell markers in people who consistently exhibit a long COVID phenotype compared to people who have consistently just fully recovered. And what you can see here is that 4 months post-COVID, those with long COVID have a significantly lower proportion of the subset of mature cytotoxic NK cells. It's actually more pronounced among the most symptomatic individuals. The observation holds up looking across different symptomatic phenotypes, but is especially prominent in people with neurocognitive symptoms and gastrointestinal symptoms. And one of the critiques of this type of analysis is that women overall have lower proportions of NK cells than men. But even if you look on the far right, solely among the women in the study, the relationship holds up. And so women with long COVID have lower proportions of these NK cells as well. And so we are wondering, based on this, whether there is reduced cytotoxic killing during either the initial phase of infection or during potential chronic infection, or redistribution of circulating NK cells to tissues where virus might be persisting. And so in that vein, this is data that we published earlier this year showing that people with consistent long COVID have increased tissue homing markers on SARS-CoV-2 specific CD4 T cells compared to people who have fully recovered, and have increased expression of markers of exhaustion on SARS-CoV-2 specific CD8 T cells. So what this suggests to us is that there's a persistent reservoir in the tissues. So when we look in the tissues, what we do is we do flexible sigmoidoscopy and get gut biopsies, and we actually mount the samples on the same slide as a pre-pandemic sample to account for batch effects. So what you're looking at here are control samples. Signal will be in green. There's no background signal on these slides. And then when we look at the post-COVID samples, they light up, and we see SARS-CoV-2 spike RNA. The top patient is 6 months post-COVID with long COVID. The bottom one is 2 years post-COVID with long COVID. The signal is in the lamina propria, which is the connective tissue layer sort of underlying the epithelium. We don't see much epithelial signal. And if you do immunohistochemistry, there's enrichment for CD68 positive cells, so we think macrophage or myeloid infiltrate around this virus. We also see double-stranded RNA, and so these are the same participants where we can identify double-stranded RNA in the tissue, which should only really be present if there's active viral life cycling. Others have shown double-stranded RNA, for example, in platelets. And now we're working to understand sort of the immune milieu around this viral signal. And what's coming out of the transcriptomic work is that there's upregulation of factors that seem to inhibit immune responses. So inhibition of cytotoxicity, reduction of NK cells, which I talked about before, and then also reductions in proteins that are sort of in defense against infections. So our take on persistence, sorry, this was a long background, but our take on persistence is that the virus is capable of persisting in a variety of different forms. This is very consistent with the discussion this morning. It's possible that it is inert and just sort of defunct RNA that is causing an immune response. It's possible that there is non-replicative translation and there are proteins being made, which are present either free-floating or in exosomes, or it's possible that there could be some low-level active replication. We think that this might be happening in immune microenvironments in the tissue, and maybe that is really the question about drug penetration, not to the tissue, but into these potentially protected microenvironments. We think that this is happening in some, but not necessarily all people. We don't identify it in everybody. But ultimately, not everybody can get tissue assays. So we really need to optimize, I think, assays on other matrices like blood to be able to identify people with this. We are way behind on this. I think Roger alluded to this before, but there has not really been any robust cross-assay validation. Everybody's sort of validating their own assays on their own cohorts. That's our big problem. And there's also a lot of variability over time within individuals that we don't fully understand, and we really need to go all in on trying to understand that in order for this to become sort of a useful line of testing. So does treating persistence matter? This is the Stop PASC study, again from Stanford, the negative Paxlovid study. So there was no benefit with a 2-week course of Paxlovid in 150 people. I think that there are a lot of caveats about this study, and it's consistent with what Dominique spoke about before. Most importantly, you couldn't screen people into the study based on confirming that they had persistence. And if only 20 or 25% of people have this, and you've enrolled 150 people in your study, you definitely have an underpowered study. And that's fine, but we really need to do some post hoc analyses to figure that out. Again, with regard to tissue penetration, I agree with Dan's point from before, but I sort of wonder about drugs getting into these, dense clusters of macrophages where the virus seems to be hiding out. I think more importantly, the duration is probably too short. So in the cat model, it requires 12 weeks of treatment to cure the cats. We are really limited by the duration of our toxicology data in people. We can't give any of these drugs for more than a couple of weeks. And it's hard to get pharma companies to invest in doing long-term toxicology studies sort of amidst all this uncertainty. I'm looking forward to seeing the biomarker results from this study. VITAL was mentioned before. I think it's going to be absolutely a pivotal study. It has enrolled over 900 people with 3 phenotypes of long COVID, is doing 25 versus 15 days of Paxlovid versus placebo. And I think even if that study is negative, there's still going to be a lot of work to do. So for the next few minutes, I want to talk about our approach in LIINC. And our approach is different from these massive studies like VITAL, which is really an experimental medicine approach that's highly informed by our experience in HIV cure. And so what I mean by this is smaller studies that are trying to interrupt a pathway of interest in a controlled manner, but we are really intense in our measurements. And our goal is to provide proof of concept in a subset of the participants to inform where we should go for larger studies. These studies do not lead to approval of drugs, and some people don't like that, but I really think that we need more of these studies to sort of figure out the path forward. So our first experimental medicine study is called Outsmart LC, and this was of a monoclonal made by a company called Arium that worked basically through the fall of 2022. So we enrolled people in this study who had long COVID attributed to an infection before the fall of 2022. And we randomized them 2-to-1, as 36 people total, to get a single infusion of this antibody, which has a long half-life, versus placebo, and follow them for up to a year. We just completed all of the 6-month time points last week, and we're hoping, so now we're well beyond the primary endpoint. So we're hoping to unblind the study by the end of the year and have sort of an initial report. I can tell you, some people feel better, some people feel the same. It's still blinded. I don't know who's who. Nobody knows what they got. So I'm really curious to see once we unblind the study. We're also conducting a study called Prevail LC. This is in collaboration with Shionogi. This is of ensitrelvir in established long COVID. So interesting data about ensitrelvir potentially preventing some long COVID, particularly neurocognitive symptoms. This is in people who already have long COVID. It's 5 days, but it has a longer half-life than other antivirals, so they get about 10 days of therapeutic effect. It's 1-to-1 randomized, and the primary endpoints are actually quite a bit earlier in the study at 10 days and 1 month. I believe there's a single spot. We have one more person to enroll in the study, and so this will report out initially probably next spring. And then based on that NK cell data I showed you, we're about to launch a study called Interrupt LC, which is of the IL-15 agonist N803, which is made by Immunity Bio. And so this is taking a different approach, basically saying we're not going to target the virus, but we're going to try to improve people's immune response by improving the coordination between the innate and adaptive immune system, which is an approach that has been taken with this drug in HIV. People will feel it. This is a very immune activating drug, and so we're curious to see what we'll learn in this study. So I wanted to take a moment and just talk about our approach to measurement in these studies. So we don't know what the best outcome measures are, right? So our approach has been to use a combination of patient-reported outcomes, objective measures, and what I call advanced measures. And so for each of the kind of core domains of symptomatology that our patients may have, We measure it with sort of a PRO that is validated. So like, for example, for cognitive function, we use the Everyday Cognition Scale. Then we use an objective measure, for example, formal neurocognitive testing, like a computerized battery or a 6-minute walk test for physical function. And then we do sort of more advanced testing, which might be a cardiopulmonary exercise test or a lumbar puncture or tilt table test. Our studies are very intense. We bank lots and lots of biospecimens. I think the biomarker work is going to be really informative. I think one of the limitations of a lot of these outcome measures is long COVID is such a complex condition. I'm not sure any one individual scale really captures kind of the totality of it. So a lot of studies are now using these global impact of change or impression of change scales, which kind of ask a patient or participant to kind of integrate how they are doing overall. And I think that there's going to be a lot of value in understanding the results of these studies, looking at those. And then I'm just going to reflect on a few things, and then I will end. Doing these trials is really, really hard. Eligibility is really complicated. There's so much variability in how long people have had long COVID, in figuring out the timing of enrollment related to vaccines, timing of enrollment related to the most recent infection, even if it wasn't the one that caused long COVID. And a big problem that we're having now is a lot of patients have to come off of their existing medications in order to qualify for a study because of drug interactions, and that can make their long COVID worse. So that's a big challenge. I already talked a bit about the duration and timing of treatment. I think something that we've not talked much about in these studies is the importance of building in pharmacokinetic analyses into the studies. And I'd like to see sort of more pharmacology engagement in these meetings and in this field. Recording and reporting adverse events in these studies is really, really challenging because people often have sort of exacerbations of their long COVID symptoms. And knowing what is related to the study and what is sort of natural fluctuation in symptoms is really hard. On-study reinfections are causing total chaos for the interpretation of these studies, especially when we're looking at biomarker evidence of persistence. And then I'll skip over this stuff. So we have an upcoming viewpoint that's coming out in Lancet ID where we sort of pontificate on a lot of these issues. I'm going to end there. I am grateful to the organizers for inviting me to speak, and I look forward to the Q&A. Thanks.